So if I introduce myself, my name is André Denault. I'm a professor at the University of Montreal in anesthesia and critical care. I'm currently working as a cardiac anesthesiologist at the Montreal Heart Institute, but I work also as a critical care physician, both at the Montreal Heart Institute, specialized in cardiovascular care, and also at the Centre Hospitalier de l'Université de Montréal, where I do general ICU.
Thank you for the introduction, Dr. Denault. How did you come to use cerebral oximetry, and how did you justify its use?
We've been using oximetry at in the hospital where I work since 2002. And initially, the only way we were able to obtain brain oxygenation monitoring was using a retrograde jugular catheter. And using this, we were able to get some intermittent blood measurement of jugular venous bulb oxygenation. And in 2002, we had the first time the ability to use the oximetry, and initially we validated compared to what we were using it before, and we were quite impressed to see how much it correlated, particularly with patient outcome. In fact, the first patient we had was a patient who had a reoperation for aortic surgery, and he started with very, very low value, below 50%, and unfortunately he did not survive. And there were significant brain desaturation throughout all the procedures, and that raised a lot of interest about the value of this type of monitoring. So since that first case, we started to study it in a more regular way, and then initially we had no idea how to use it, so we developed an algorithm which I published in 2007 with John Merkin and Alain Deschamps. And then in 2013 and 2016 we validated the algorithm in the use of NIRS.
On what type of patients do you use cerebral oximetry in the intensive care unit?
Yes, we typically would find them useful in those patients who are hemodynamically unstable, okay? Because the oximetry is influenced by your oxygen transport and your delivery. So those unstable patients, if you do an intervention that will improve their oxygen transport, or if the intervention is successful or not, you will see it on the oximetry signal. The same way as if you use capnography, capnography will tell you also the same information. The only problem with capnography is that to use it as a continuous indirect measure of cardiac output, the ventilation has to be constant, and this is not always the case in patients in the ICU. So the advantage of the oximetry is that you can use it regardless of the mode of ventilation or the regularity of ventilation, but also you can use it in patients who are extubated, who are not ventilated, and then that can be used as a way to detect impeding oxygen transport compromise. So I find it very useful in those patients in order to monitor oxygen transport.
When you first started to use cerebral oximetry, what action did you take when you observed a drop in RSO2?
When you have desaturation, you want to know why exactly, and you want to know exactly what's the problem and what's going on. So for instance, just give you an instance, if you have pure brain desaturation, first step you'll check your ventilation, maybe get a blood gas. And when we started to use these monitor in 2002, 30% of all the brain desaturation was just because we were ventilating those patients with too much ventilation. Okay? We thought the ventilation we're giving was normal, but in fact, we were giving them a normal ventilation, but on a patient who is hypothermic, under general anesthesia. So basically, the ventilation we were providing was way too much for their CO2 production, and this is why they were having desaturation. So this type of problem of hypocapnia-induced desaturation has I would say not completely disappear, but is almost gone since we start using this modality.
How often do you see unilateral desaturation?
Unilateral desaturation is quite rare. We see this, I would say, less than 1% of the time. But there's some situation in which patients are more at risk of having unilateral desaturation. And these are, for instance, if you have aortic dissection, if you're doing congenital heart disease, if you have a patient who is known to have endarterectomy, or he has a carotid artery disease or vascular disease. These are situations in which there is a risk of having unilateral desaturation. So this is when you might consider using dual electrodes, both on the right and on the left. And in fact, this week we just had such a case. We had a patient who went for congenital heart disease, and we had unilateral desaturation on one side. And those desaturation are typically secondary to either an arterial compromise of flow, like for instance if you have a dissection of the carotid artery, or if the surgeon is putting a cannula and the cannula is obstructing the innominate artery, then you could have unilateral desaturation, but also venous compromise. So in the case we had this week, the patient, during the cannulation of the superior vena cava, there was a unilateral desaturation, and I was talking with the pediatric, the congenital heart surgery surgeon, and she was telling me that this is quite common. So when you have venous compromise, it can start on one side initially and then go on to the other. So what we did when it happens, we repositioned the head, we took the ultrasound, we looked at the carotid. But the good news is that we had transcranial Doppler on this patient, and there was no change in the transcranial Doppler, which indicates that there was still adequate arterial perfusion to the brain. And eventually, when the cannula was removed, everything went back to normal, and the patient woke up without any without any neurological deficit. We have patients under ECMO. We would monitor both sides of the brain, because those patients, particularly arteriovenous ECMO, they can get unilateral brain desaturation. In fact, they have a name for this. They call it the Harlequin facies. So half of the face change color compared to the other one, and that can be sometimes a sign that there's abnormal oxygenated blood that comes from the heart, because the lung is not functioning adequately. So this is a very important sign that we look for those patients, and this is when monitoring both sides of the forehead in ECMO patient is something I think is going to eventually become a recommendation for those patients.
What is your experience with low absolute RSO2 values?
In terms of absolute value, well, what we know is that the absolute value will depend on several factors. And there was a nice study showed that patients who have low value to start with are typically patients with anemia, with low ejection fraction. Patients often are on hemodialysis. And also these patients can have what could be considered a sort of cause of artifact, is that their distance between their skin and the skull is significantly increased, those who have lower values. In some instances, especially if none of those elements are present, that can be an artifact. And the most common artifact is when you put the electrodes just above the eyebrow and in the very medial region, where in some patients you can have very high frontal sinuses. So if these frontal sinuses are very important, that could lead to falsely low values. So some people have suggested that when you put the electrodes, you might put it more in kind of the aspect of a letter A, instead of just putting them completely horizontal, in order to avoid the frontal sinus. And sometimes you just put them a little bit higher up, and then the value goes back to normal. So that's always important to keep in mind. These very low values, we see them rarely. Again, it's not very common. I remember a clear case of patient who had a liver transplantation, his value were very, very low, like below 20, and this patient was doing very, very well. And when we had the CT scan of this patient, there was clear, very, very high frontal sinus. So it's always an issue to keep in mind when you have very low values. But most of the time, low values to start with are associated with a reduction in, I would say, the ability of oxygen transportation, such as cardiac function, reduced cardiac function, or anemia.
How did you convince your administration to invest in the cerebral oximetry?
In terms of overall outcome, again, it's very difficult because there are so many factors that will affect good or bad outcome in our patient that it's hard to say, well, this was really an important. But that's just to tell you that, you know, these elements for us at the Heart Institute are modalities like brain oximetry and EEG. We use them routinely in all our patients. That's something. And how we were able to convince the administration that for us, it's in terms of quality of care, and we want to make sure that if there's any brain desaturation or if there's any over sedation, which is more common than under sedation, that we can detect on the SED line, we will be able to react appropriately.
Can you attribute improved outcomes to cerebral oximetry?
If you just take pulse oximetry, and those who know the literature about pulse oximetry, you'll find there's no study that has shown that pulse oximetry improve outcome. However, it is a monitor that we use routinely every day, and there's no anesthesiologist, there's no operating room who doesn't use a pulse oximetry. And every anesthesiologist have seen situation in which a pulse oximetry will start to fall before you could pick up that the patient is becoming blue. And this is what was done before. So the real advantage of oximetry and SedLine, it tells you that something is happening in the brain maybe at an earlier stage before it's too late to intervene.
Please describe some cases in which cerebral oximetry changed your practice.
We had several cases in which, you know, there was a cannula misplaced that we repositioned right away, and it was associated with unilateral desaturation. There were situations in which there was inadequate oxygenation. The oxygenation was the PO2 was starting to fall, but you wouldn't pick it up with your pulse oximetry. But you would pick it up with the brain oximetry, and then find out that the patient was bleeding in the thorax, and you would correct that. So there's been several situations in which this monitor was playing an important role in the care of our patients. But there are so many other things that are important in the care of patients that's saying that's okay. If you just use this, you'll have a change in your outcome. It's very, very difficult to demonstrate. What we can demonstrate, however, is that there's been many interventions that we are doing that we have changed since the introduction of those monitors in our operating room.
Thank you for listening. To learn more about Masimo's O3 regional oximetry, please visit masimo.com/O3.